Thank you very much, Mario and Eric. And this is my disclosure slide. One important thing perhaps to disclose is that the BIOS, beside the advisory role that I have had with some companies, all the views that I'm going to be presenting here are my personal views and do not have to coincide with the views of the European Society for Medical Oncology. So basically, in the mission of ESMO, we, as important pillars, we do not only have integrating cancer care and education, of course, for our members and also for the patients, but more importantly, what we really think it's a challenge for the future, and this is sustainable cancer care. It's not only to promote the quality of treatment, but also to promote the access for this treatment, and also for cancer prevention, of course. So let's see some features, some figures where we are right now. We all know that the burden of cancer is increasing over time, especially because of the numbers of patients that are diagnosed of cancer. And here you have the figures from 2015. But it's really predictable that in the next years, especially until 2025, it's going to be an increase in the number of patients with cancer. And also we know that on top of all this situation, on the increase in the number of patients that we have, it's going to be really very important, as we see right now, the increase in the cost of the therapeutics of cancer, especially for cancer drugs. And actually, if we go in more detail to these numbers, you can see the report. This is published frequently by the EMS Institute, and basically, there is an increasing of the cost of cancer drugs in the past years. So these are statistics covering a period between 2010 and 2015. And basically, you can see that in the last 5 years, the increase in the cost of cancer drugs in the United States has been as high as 70%, and in the rest of the world, around 50%. Obviously, if we look at the global cost of cancer, the number is $107 billion in 2015. And what we see is that there is an increase of around 11%, 10%, 11% year by year. Actually, the predictions do not look very well in terms of cost. Obviously, this looks well for patients because patients have more opportunities, but according to the same report, the predictions of the increase in the cost for the drugs are going to be mainly in the area of oncology. May I have access to the mouse? Okay. Anyhow, as you can see here, okay. The cost basically is going to be, the increase in the cost basically is going to be related in the area of oncology and immune modulators. There are other areas that is a small increase, for example, in the endocrine therapeutics and also in hemostasia, but most of the cost, at least the prediction until 2020, it's going to be related to oncology. And actually, if we look at the numbers year by year on how the cost increase, either for small molecules or for monoclonal antibodies, you can see that the increase is around 8%, 10% for small molecules. You can see this in the dark blue. And also for monoclonal antibodies, that is rapidly increasing at the bottom from 10% up to 17%, for example, the increase between 2015 and 2016. So the problem is there, and the worst probably has to come. So if we look at the CAR-T therapies, actually these are treatments for very selected patients, but with a high potential for cure. The price is increasing very rapidly, and this is one of the reports that analysts did about the acquisition by Gilead of the company Kite Pharma for almost $12 billion. And actually, the analysts predict that when these compounds are going to be accessible for the patients, the calculation of the cost for each individual patient would be around $700,000. So no doubt that the costs are increasing over time. And how this translates to patients' access for these drugs? Well, the way that usually the regulatory agencies do is that they promote as rapid as possible the regulatory approval of the drugs. But when we look at the reimbursement of these drugs in the countries, there is a big difference on that. And in this calculation, also by the IMS health report, they consider whether there is full access in one particular country or no full access. So it's a black and white calculation. But the point is that if you look at the drugs that have been launched in the period from 2010 and 2014, actually we are not doing very well in getting these drugs fully accessible for patients in the different countries. So you can see here, different countries, red is none, fully accessed, yellow is fully available. And actually some of the countries in the European Union, but also in other areas, are not doing very well. And the situation is even worse if we consider the drugs that were approved in 2014 and 2015. For example, Spain is the last one, meaning that not all the different regions have access to the drugs that have been approved by EMA, but also you can see some other countries that are in the middle and we are not performing very well. Basically, the payers or the national health systems, in this case, are protecting themselves by delaying the mechanism on how drugs are being reimbursed for all the patients. And actually, I wanted to quote here two quotes from the past presidents of both ASCO and ESMO, basically saying that health is a human right and the society should favor that patients have equal access to optimal cancer care, and this is from Fortunato Giardello, but also Dan Hayes mentioned that medicine doesn't work if it does not get to the patient, which actually it's obvious. How this translates into disparities in cancer control in Europe? Basically, in Europe, we have done several surveys from ESMO in trying to look at how these disparities may affect the population of patients in this setting. So in this slide, in the first cartoon, you can see the incidence of cancer. The important thing is that there is more incidence of cancer in the northwestern countries. But actually, when you look at the survival is the opposite. It seems that the worst survival is more located in eastern countries. And one of the things for this difference in survival is related to cancer drugs access, of course. And ESMO, as mentioned, has done several surveys in order to address whether there are differences and how this difference could be changed in the access for these drugs in the European population. So in looking, for example, at one tumor area, this is non-small cell lung cancer, and you can see here some of the targeted agents that we have in the clinics, like erlotinib, gefitinib, crizotinib, and some others. In the Western Europe countries, most of them, actually these compounds are fully accessible for patients, either by free or by cost paying of less than 25%. This is the situation in most of the countries. But in the other side, when we look at the eastern countries in Europe, the situation is very different. Red means that patients have to pay full cost of the drugs. Black means that there is no access at all. So the situation is really very different. Also, we have to realize that according to the total cost of cancer care per person, the cost of drugs, it's around 27% as an average in the different countries. But also in looking at the cost of the drugs in some countries in the European Union, and also including here Australia and New Zealand, you can see that there is a difference of the cost of the drugs that varies between 28% and 388%. So quite remarkable, the difference that the countries at the end, the payers have to pay for the drugs. So the situation is really very tough, and for this rational and these major points that I mentioned, ESMO took several actions in order to promote and to facilitate equal access of cancer drugs to all cancer patients. The first thing is to create a cancer medicines working group, and this was created in 2015. I had the privilege to chair this working group at the beginning, and we focus in two particular areas. The first one is the essential medicines, those that are not more innovative, but are essential for treating patients with cancer. And you can see here that actually there are several problems related to these drugs, especially shortage of drugs, growing disparities in access within the European countries and beyond. Obviously, we are tackling this problem in a worldwide level. And what we did here is to address the problem and to have real statements in a collaboration with the Economist Intelligence Unit, and we developed a report addressing this medicine shortage in Europe. And actually, we were able to launch this report at the European Parliament, and this was really very important because the participating countries took in consideration this, and they came with this important problem into the agenda of the respective countries. This was number one at a glance. Also, we have done a working group in what we call expensive and more innovative cancer medicines. And as in here, we all know that all these new drugs that are, some of them very active for patients, are not available in all the different countries. And in here, we have done several actions. One of them is to collaborate with other stakeholders because it's important that we raise that this is a worldwide problem. So we have collaborated with WHO in the Fair Pricing Forum, also with ASCO, with the American Society, in order to build joint symposiums just to address the problem of access to cancer medicines, but also in other areas that I will mention later on. So basically, which is the problem? Just an example that is not related to the gastrointestinal tumors, melanoma. Melanoma patients actually did very poorly when we only have drugs like cisplatin or the carbazine. But the cost of treating a patient with the carbazine was around $2,000 on a yearly basis. When we had these exciting drugs like nivolumab, ipilimumab, pembrolizumab, and others, if we take the cost of treating one patient in the United States, this is data from the United States, with nivolumab and ipilimumab for 12 months, actually the cost increased up to $300,000 for patient, right? And more, our systems in a worldwide basis are considering which is the real value of implementing these drugs. Of course, in melanoma, this is very clear, right? But at the end of the day, we have to address which is the individual value to treat one patient with one treatment or another. And our systems and our societies have to take this problem in consideration. For example, at ESMO, we are working with a tool and a position paper that could facilitate the discussion between the pharma companies and the payers in the different areas of the world. Because we as a professional society are in the center of the problem, and actually we had quite independent way of seeing that, and we could promote this kind of dialogue. For example, if we look at one particular drug, in one particular tumor, we could calculate the value of that drug in a referral country, like for example, Germany or Switzerland, the one that we decide. And this is going to be obviously based on the GDP of the country, also on the percentage of health cost of the GDP, and also, and as we mentioned before, on the consideration of the magnitude of clinical benefit scale, and of course the frequency of the disease. And when we want to translate this to another country or another region, we could easily consider which could be the range for the discussion in considering also the regional or the country parameters according to the GDP, again, the percentage of GDP in health expenditures, but also in considering the frequency of the disease. Obviously, this is going to be a tool that could facilitate this dialogue. It's not that ESMO is going to be considering specific discussions for specific drugs in the regions, but at least having these kind of tools that at the end would promote this seminal concept that is the geographical adapted value-based reimbursement. So reimbursement adapted to the value and to the geographical parameters of the different, economical parameters of the different geographical regions. The other point is to promote a value-based characterization of the drugs that are approved by the regulatory agencies. And in here, ESMO promoted the magnitude of clinical benefit scale by the committee with the same name. And in here, we are not alone, as you know. Other important stakeholders like ASCO, Sloan Kettering Abacus, and NCCN, among others, have also contributed to the field. The bottom line here, at least for the magnitude of clinical benefit scale, is that we want to grade the activity, the efficacy, and the safety of the drugs according to these parameters and try to rank the drugs with the different approvals in a classification that can be easily managed and used by patients, by physicians, by payers, by national health societies, of course. We don't consider the cost, because the cost, as I showed you before, has strong, tremendous variation between the different countries and regions. But this is something, obviously, that has to be considered in a different table, perhaps with a value-based reimbursement tool that I mentioned you before. Tomorrow you are going to have a session where Jean-Yves Douillard, the ESMO CMO, is going to address the magnitude of clinical benefit scale, and you may be familiar with that, but basically we are categorizing the drugs in the curative setting from A, B, C. A is the maximum level, and in the non-curative setting from 5 to 1, and 5 and 4 are the maximum ranking for drugs in particular approvals. So this is also an example that I took not related to GI, and in this way, actually, we can comment easily on that. If you look at the different drugs that have been regulatory approved by the European Medicines Agency, and on the right side, you will see the scoring, and you can see that the scoring varies from 1 to 5, so there are drugs in particular settings that work very well. This is a 5 or a 4. And then you have other drugs that the activity is not as high, and they are 1 or 2. If we look at the drugs that have been approved by EMA since 2016, actually you can see that there is a wide distribution of the ranking of these drugs from 1 to 5, and there are very few actually with 4 and 5. But when we look at the cost of these drugs on a monthly basis, actually the cost is very similar. You can see this has been done by ESMO on the right side with the ESMO classification, and also by ASCO with the value framework in the left side. And the bottom line here is that the cost of the drugs in a monthly basis is quite constant. I mean, probably because the cost or the price of the drugs has been mandated by the market rather than by the real value of the drug in each setting. So what else can we do from ESMO besides promoting this value-based reimbursement? The second thing is to promote as much as possible academic clinical cancer research. And we have to realize that most of the therapeutic breakthroughs on the last years came initially from academia. And also that 65% of the clinical trials globally are supported completely or in part by the health systems, the government funds, the universities, and other research organizations. So we should also consider and to put this in value, because actually at the time that the drugs are approved, perhaps we should think a little bit more on how public fundings and academic institutions contributed to the development of that particular drug that may be really very relevant for patients. So what we did at ESMO, in collaboration with the EORTC and the European Association for Cancer Research, is to promote a dialogue about how important is academic research in our environment. And for that, we created the Clinical Academic Cancer Research Forum called CARE4, in trying to address important topics to promote and to secure as much as possible academic research. And here we address how important is this kind of research, also involve all the key actors, all the stakeholders that could promote fostering this research. Also, how to lobby at the European institutions in order to safeguard and foster this research, and also to have a voice on the implementation on the European Union clinical trials and data protection regulations. This has been nicely posted and stated in an ESMO Open article that I encourage you to read. And we addressed several important questions about the sponsorship from academic clinical trials in order at the end to foster as much as possible this academic research that is really very independent. Also, another point of navigation in this field is to discuss about the Me Too, or the too many drugs that are very similar. Also looking at a report published by Tito Fojo several years ago, 4 years ago actually, in looking at the biggest pharma companies and how the cancer therapies that they have in the pipeline could be identified according to the mechanism of action and whether this mechanism of action was overlapping or not overlapping between the different companies. Actually, you can see that the reds are overlapping mechanisms or even overlapping targets, and only the yellows are non-overlapping mechanisms of action. So this is something to consider in mind, because if we foster and we promote many Me Too's, I'm not saying that there have not to be Me Too's, but if we promote many, actually we are hampering other areas that are essential for clinical research, and this is also something that is very important. Also, the advent of biosimilars. We consider biosimilars as an opportunity actually to reduce the cost of some drugs in order to promote the innovation in other areas. So what we can reduce of the budget, it's going to be implemented in other areas, no doubt of that. And actually ESMO has promoted an intense discussion of biosimilars with all the stakeholders, and we published this paper in ESMO Open 2017 that basically represents the opinion of the society. And here we have to recognize that EMA and also right now FDA have done a very good work in order to promote the quality of biosimilars in the way that they are approved. This manuscript, of course, has been highly cited and downloaded, and we are really very happy about that. But it's also important to discuss with all the stakeholders, especially the physicians, the prescribing physicians, and the patients, important aspects about switching and how we are going to use these biosimilars in considering also extrapolation rules for administering these compounds when the clinical development has been done only in one particular area. But what we all know is that biosimilars that are approved by FDA or EMA have a very good process of preclinical development, clinical development, and the regulatory submission, of course. But more and more we'll have to discuss all these aspects, and especially think about that automatic switching should not be an option. Basically because we have to inform our patients about the reality of the biosimilars, but also we have to do an important monitoring of the patient just to look at potential immunogenicity-related adverse events. But this is something that we have to discuss more and more. And ESMO has been promoting this in the past years, not only in the regular meetings with colloquia and forums on biosimilars with all the stakeholders, of course, but also at the European level in trying to have stakeholder events with the European Commission and also with the working party of the European Medicines Agency. Finally, the last point is that more and more professional societies like ours should be involved in the discussions with policymakers. And actually, I think that more and more we should empower the societies, the professional societies, and ourselves to lead in part this discussion. Because as mentioned, we are in the middle of the problem with the patient. So we have pharma companies, we have organizations, we have national cancer plans, and we have the payers, among other stakeholders. And we have to try to do our best with the budgets that we have in order to promote that patients receive the better access. And tools like the value-based reimbursement model or the magnitude of clinical benefit scale developed by ESMO may foster this kind of discussion in a very open way. So this is a problem that all we have. We have considered that it's an universal problem. And again, as many stakeholders we have in the discussion from the early beginning, we have more chances to succeed. So my final slide, as a summary slide, I just wanted to demonstrate you that ESMO is doing several actions at the level of ensuring cancer care access, not only medicines, but in part for medicines, with the magnitude of clinical benefit scale, with the cancer medicines committees that we have for the essential medicines, and also the expensive innovative medicines, and also our position on biosimilars. Where's the next? This is a sentence that Usain Bolt, that was, as you know, was a famous sprinter from Japan, from Jamaica, sorry, said some years ago, he didn't think on limits. Actually, we shouldn't do as well. So we think to do all together. I want actually to give credit to the many people at ESMO in the different committees and working groups have collaborated in all these discussions and promoting these tools and these papers. Here you have mentioned the members of the different committees, the Public Policy Steering Committee led by Paolo Casali, the Magnitude of Clinical Benefit Committee right now led by Elizabeth de Vries, as well as the Cancer Medicines Committee. Also the leadership at ESMO with the presidents, the CEO and the CMO that prompted this kind of dialogue far back in 2013, and this was really very important. The ESMO staff that collaborates in this. Also, the other stakeholders that have collaborated in this nice trip on doing these important products, and also from my local institution, Amanda Wren. Thank you very much.